So good evening, everyone. Thank you for joining us today. We know we are all going through a very difficult time at the moment with the increase in cases in COVID, and we hope you're keeping safe and you're keeping well. Today, April is the month of Head and Neck Awareness Month, and so we thought that we would focus on dealing with changed appearance in head and neck cancers, what are the options available, and how you need to cope with it. Quick introduction on Patients Engage as, sorry, Sheetal, next slide. So as some of you are already aware, Patients Engage is an online platform. We have been operational for over 5 years, and we strongly believe in evidence-based and holistic management of chronic conditions. And we look at it in terms of, what the patients need, what caregivers would need in terms of information, because we strongly believe that with better information and, access to the right kind of information, people can make better decisions and improve their quality of life. We've been doing a series on various cancers. We've done childhood cancer. We've looked at it from the perspective of the fear and stigma. We've looked at it as to what happens when, they become young adults and go out in the world. We've looked at how it's challenging to navigate care, especially for some of the osteosarcomas. Next slide, please. Thank you. We've also looked at various issues related to breast cancer. So from hormone therapy to issues related to body image, to managing lymphedema, to staying fit after breast cancer as well. So again, we've looked at patient voices. We've looked at, experts, oncologists, as well as bringing in, counselors as well. We've also looked at, next slide, we've also looked at how, relationships are affected in cancer. So we've had discussions around how to talk to your children about your cancer. We've talked of how children dealt with when their mothers had breast cancer. And we've also looked at, aspects like psychosocial effects of stoma bags, especially for bladder cancer. We've also been doing head and neck cancer or oral cancers. So this is the third in the series. The first couple where we've also done other cancers like bone marrow and hematological cancers, and we've talked of cancer prevention as well. So, and moving on to the cancers related to oral cancer, which is what we are talking about today. We've covered a patient voice in terms of, and an advocate on saying no to tobacco. So we had Mehul Shah, who's a cancer survivor and a strong, passionate advocate of anti-tobacco. We also had dental rehab covered with Dr. Meghna. And we then talked to caregivers about the challenges, as well as how they can support patients, as well as what is the kind of support caregivers need as well. So we covered a wide range of topics from nutrition to relationships and staying positive as well. Today we have with us a panel of, it's an interesting panel. We have Michelle Normen, who's a psycho-oncologist at CyteCare Cancer Hospitals. We've got Dr. Aditya Patil, who is plastic and reconstructive surgery, who does a fair number of surgeries related to head and neck cancers. We also have Urvi Sabnis, who most of you who've been following us know. She's a key member of the Cancer Power Circle, as well as she's a patient supporter. And she actively works and counsels various patients. Next slide. So for all of you who are watching on Zoom, you can put in your questions in the chat option or the Q&A. If you are watching on Facebook, you can put in your questions there and we will address it from there. Do remember that this information is not to be, you do need to consult your doctor for specific medical issues. This is generic information that we will be addressing at this point, and it's based on the experience of the panelists. This session is being recorded and will be uploaded on YouTube. And if you're logged into Zoom, you can post your questions on the Q&A. If you're on Facebook, you can post them on the live feed, as I said. And as always, you can write into us at editor@patientsengage.com. And you can follow our website, patientsengage.com. You can follow us on our social media pages on Facebook, Instagram, YouTube, Twitter. So I think we will stop sharing now and quickly move on to the discussion. Just a quick reminder to all of you, head and neck cancers is a wide range, and it covers the oral cavity, it covers the larynx, pharynx cancers, the nasal cavity, the cancers that are included as part of it. So let's get started. Let's look at it from a pre-operative and post-operative perspective first. So in the pre-operative, Dr. Aditya, what is the role of plastic and reconstructive surgery with respect to head and neck cancers? Sorry, let me also ask Sheetal to take over the questions. Sheetal is co-moderating with me, so because I think I'm having a bit of internet problem. So go ahead, Sheetal.
Okay. Thanks, Aparna. Good evening, everyone. So like Aparna mentioned, I think some of it got missed out. Head and neck cancers is a term that is used to describe a wide range of tumors that can be in and around the throat, the larynx, which is the voice box, the nose, the sinuses, and the mouth. So which includes your tongue, your gums, your palate, upper palate, lower palate, all of that, right? So Dr. Aditya, when for head and neck cancers, surgery seems to be the first line and the main line of treatment. So what is your role in this, in head and neck cancer surgery?
Yeah. So like you just said, there are a number of different areas of the head and neck that can be involved in the malignancies. Also, the malignancies can be benign and malignant. And so the treatment varies according to that. But when we talk about head and neck cancers, there are primarily two aspects that we see. One is the resection part and the other is the reconstruction. So in smaller cases, when there are smaller lesions, in earlier lesions, both resection and reconstructions can be done by the same surgeon. But in more advanced cases, a specialized plastic and reconstructive surgeon is required. And there are two teams in this case who work together in tandem. So the first one would be the resection team that deals with the resection or the removal of the tumor or the cancer. And then I come in, or as a plastic and reconstructive surgeon, we are the second team which deals with the reconstruction of the tissues that has been removed. And when a tumor or cancer is resected, some part of the normal tissue also sometimes has to be removed as a margin to provide an adequate clearance. And this leads to a formation of a defect in that area, for example, from a cheek. So the cheek has to be reconstructed. And if the defect is relatively small, it can be closed by just stitching it up. However, if the defect is bigger or in advanced cases, and if the direct closure with the stitches is going to lead to some deformity or asymmetry, then reconstruction comes into the picture. And so reconstruction can be done with the help of any local tissue rearrangement, which means using the skin in and around the area of the tumor, or it may entail using skin and other tissues from an entirely different part of the body, which are then put into the defect and all along while we try to achieve function and symmetry of the face.
Okay, so you mean to say that the options for the reconstructive can be both skin, muscle and bone, right?
Yes, so that depends on what part of the body or what tissue has been removed in the cancer. If only the skin has been removed, then we replace it with only skin. that may be again from the local area or from the other part of the body, which can be skin grafting or skin flaps. And if for example, a bone has been removed, the lower jaw is very commonly involved in tobacco chewers. So if the bone has to be removed, then the bone has to be replaced by bone. So then we take bone from elsewhere from the body and then replace that bone with the bone, most commonly the fibula.
And are there any options given to the patient regarding the surgery? Is a patient asked what kind of surgeries are possible and if they have a say in it?
Theoretically speaking, there are a couple of options for reconstruction following a head and neck cancer removal. So, of course, all the decisions are taken along with the patient. But in a few cases, there may not be many options left to the patient. And in those cases, we advise the patient regarding the best possible treatment. And all the options may not translate into being practically successful. Let me explain with the help of an example. Like I mentioned, the jawbone, when the jawbone has been removed, the ideal reconstruction would be to replace that bone with another bone. The patient does plate, which is a metal plate, which can be used to bridge the gap. But this is not a biological tissue, and over time, it tends to get exposed, it gets infected and other things. So there are other options like prosthesis or implants, camouflage, makeups, and all those things. But none of those are long term in their results, and hence reconstruction always has to come up. And regarding the choice of reconstruction, of course, we always discuss with the patients. There are one or two options which we can discuss. For example, some people may not recommend taking a skin from the hand because it's more visible. They may only consent to the skin being taken from the thigh and so on, like that. Yeah.
But a lot of this reconstructive surgery sounds like it could be really lengthy and expensive as well, for some of the patients. So I'm sure that's a big consideration for a lot of patients, even for the elderly. Can they withstand such a long procedure? So if they do opt out of it, can they function without the reconstructive aspect?
So, yeah, sometimes finances do come in the way of reconstruction, and age, sometimes comorbidities like diabetes, hypertensive patients, they are not an absolute contraindication. It's not like we can't do surgery in these cases, but yes, sometimes we choose not to do lengthier surgeries like you mentioned. So in a few cases that are detected earlier and which are relatively small, reconstruction may be an option that can be left to the discretion of the patient. However, in the vast majority of the head and neck cancers, reconstruction becomes almost necessary and almost mandatory. And maybe they don't have an option to refuse reconstruction, but we can go for a slightly lower down the ladder, some smaller reconstruction, something which can be done faster in view of the patient's health. So yes, that can be done.
Did we lose Sheetal also?
Yeah.
Okay. I think let me ask Urvi and Michelle, what are the emotional aspects of the changes in appearance? Because I think that's the one thing that, it keeps coming up because it is one of the most visible cancers, I think, that happen. So Urvi, if you can tell me first in terms of, what you see when you talk to your patients and the caregivers, and then Michelle will come to you as well.
Yeah, so basically it is like anger, guilt, depression, sometimes like deep depression, you can say. So this would depend on various factors, like I would say how, which type of family they come from, whether the outer appearance is given much importance, so much importance in the family. These all things, like there are plenty of things on which it depends. But I would say that everyone, each and every patient has to go through the process of accepting the change in the appearance, body image. And that is a process, like you can say, it again varies from patient to patient, how long it would take. But
right. Michelle, from your perspective, what have you observed as far as that emotional aspects are concerned?
Right. So predominantly two things. One is age and gender. I think everything works based on these two factors, and people differ in terms of how they emotionally react or respond to appearance in a sense. We are looking at even loss of control, with knowing that you have cancer and then knowing that you have to do a surgery that might disfigure and lead to kind of functional related changes, which in itself, is like, I don't have the decision to make. And like, we were just talking with Dr. Aditya about, do they have options? I mean, I think it's like push comes to shove, like the doctors themselves are pushing them to get help. And I think there's not much time to process these things, So I think the whole concept of even body image, like, I mean, there's so many studies that talk about it, or even self-image for that matter. Now, these are such varied concepts, which obviously make this whole thing much more emotional, I were to say. And yes, stigma is something that definitely puts them at the back burner of a lot of things, and isolation for a fact. So if they are going through a lot of emotional issues at the point of knowing that they have to have surgery or have cancer, then they are going to kind of feel isolated. They might withdraw. And like Mrs. Urvi was saying, the depression that can follow is very, very real with it. We're also looking at identity crisis at that point in time, and the effects it has on activities of daily life. So I can't say that this is just emotional, and I can't say that it's just a reaction, but it's something that happens over a period of time, and it affects, everything from their eating, their sleeping, the kind of fatigue that they might experience. And also if pre-op, they have a whole lot of issues, which is what happens, I think, in head and neck cancers in India, especially, that they come in at quite an advanced stage. And, it's just focused on, cure as against, what happens to the person sometimes. So it becomes very difficult to kind of like, get them to completely stay away, to kind of process this, or, have an emotional breakdown at that point, because they have to just make these choices, unfortunately, without much time. And the last thing I want to say is, tobacco use in general is associated with a lot of self-esteem related issues. So you're looking at somebody who's going to come from a pre-morbid, personality or characteristics that are not going to be coping very well. And to put them in a situation like this, is, so it will take time.
Right.
Come back and root them into kind of like a here and now to, understand emotional issues, I would say.
Right. Yeah, that's a very interesting point you said, that, the fact that they are tobacco users or in some cases alcohol users means that they do have certain, dependencies. I guess I had a question for you, Dr. Patil, Dr. Aditya, is that are there options for them to choose to kind of defer the surgeries, or, I mean, the reconstruction part of it, or that's not really an option? Because that's just come up from the audience as well.
I kind of lost you midway. Can you please repeat?
No, so I was saying that, is there an option to defer the reconstruction? So, you kind of do the basic surgery and then you do, like in the case of breast cancer, right? There is an option to do reconstruction as an optional. So is there that option at all?
So you just do the resection without?
Not in all cases. Like I said, if it's a small cancer, if it's an early cancer, if it's a small basal cell, something called as BCC, that's a basal cell carcinoma, maybe they can just remove a small part and do a local reconstruction. They can just stitch it up. So that is okay. But if it is a slightly bigger resection, when after resection, if only stitches are going to be put, the scar sometimes is not very good, or sometimes the symmetry goes away. If they remove a big part of bulk of the cheek and then they stitch it up without doing any reconstruction, then the symmetry on is going to be different. There's going to be some disfigurement. So it will need to be addressed. The volume of tissue that has been removed will need to be replaced in some sort of way, either by fat or skin or muscle or something like that. So I don't think reconstruction is an option left entirely to the patient or to the doctors. In some cases, we have to go for reconstruction. But yes, we can let the patients, we can not let the patient choose, but then we can discuss with the patients regarding whether we should go for this option or this option or this option. But the option of not getting reconstruction is a little tricky in larger cancers.
Right, right. And coming back to you, Michelle, and I'll come to you as well, Urvi. Urvi, is how can the patient and the family, I know you said there's a very short time, so how can they prepare themselves to, in that pre-op time?
Right. So we have something called as cancer rehabilitation. I don't know if you're aware of the word. So basically, this is where multiple teams come together to understand from a physical point of view and from a psychological or social point of view as to how somebody is ready to take on something like a huge cancer surgery, for example. So it's basically to kind of give the patient and the family some amount of preparation to understand their current level of psychological functioning, physical functioning. So physiotherapists usually come on board, try and understand what is their level of functioning at that point, because what happens is we literally do before and after. So like I was saying, sometimes they present with very high physical related concerns, which might be already debilitating of a sort, and to expect that it's going to go back into something, completely new is kind of, that it's going to be new normal, like they call it. And for that, one must be kind of in terms of reality to know that there will be disfigurement, there will be issues with functionality. So what do you understand about it? What do you want to do about it? Do you have a plan, or what does your family understand about it? Because I think a huge chunk is about what the family thinks. And I guess in most hospitals, this might be absent because, like I said, time is short, referrals. And at that point of time, like even Dr. Patil was saying about getting them to get, assessments for even their pre-anesthetic workup and making sure even their comorbidities are all under control and things like that in itself takes up a huge amount of time, and multiple visits to the hospital sometimes makes it difficult. So I would say empowering at least the nurse or whoever is there. I think even the doctors do a huge chunk of counseling where they tell them that these are the things that might be expected, what are the things that you need. And if they have the luxury of having somebody from psychosocial support, then definitely giving them a plan. So we usually tell them that we will see you before and we'll come back and see you in the ICU. And if it is, especially if they have like, they're not able to talk, they have a tracheostomy or something like that, then we get them a pen and a book like already, so that, there is no room for, oh, you're going to struggle to talk or you're going to do sign language and nobody's going to understand you, because frustration, anger, and all of those things build up usually at that time itself. And obviously, we are looking at how adaptively we can make them cope, even when we see them pre-operatively, and to get the family to get on board with us to say, hey, he's not or she's not going to be the same person after surgery. You need to, understand that there is going to be disfigurement, which might be unappealing, I would say, to a lot of people, but the person is still that person, so love that person for who they are, or care for them the way you would want them to care for yourself. So it sometimes becomes a challenge, but like I said, it depends on pre-existing personality to a great extent. And I would say that if there is difficulties, then post-op, it's going to be a difficult time. So if they are very rigid, if they are very stubborn, if they are the head of the house, for example, who doesn't want anybody else to make these decisions, then to hear it from somebody else, even from a professional point of view, sometimes becomes difficult. So I guess it's about here and now, and at that point in time, what works, to be really honest. So yeah.
Urvi, I think right post the surgery, when there's so much swelling And, I think that is possibly the worst time. Would you agree?
Yeah, so I would like to add something to what Michelle said about this pre-operative stage. Like initially, when patients come, they are concerned about their survival more than the body image. They want to get the cancer out of their body, and so at that time, they are not that much concerned. They are, but not to that. The gravity is less at that time. Like we try to counsel the family members more that they should be ready for the change in the appearance and how they should address the emotions, like when the patient is out of the, because generally what happens, like we all tend to talk positive things. We although it is very well meant, but when you see the patient out of the OT and the stage which you talked, Sheetal, that the patient is out and we start saying, you look good, you're doing well, it doesn't go well. And when Michelle talked about the gender thing, I've seen that men, they don't open up very fast. So we need to give time to the patient to open up. They also need that space, proper space to talk out. If they want to cry, they want to shout, whatever they want to do, we need to give that space to them. And then we can address their concerns, like what are the concerns that we need to understand. Yeah.
And would be like age also matters quite a bit, right? For an elderly who's retired and sort of, doesn't have to go back to work and things like that. It's a different scenario, right?
But I think I just want to add that I think we will be pleasantly surprised that appearance, even though I think in our culture is given so much of an importance, and especially if there are women who have head and neck cancers who've not been users of tobacco and ask you, why me? It is definitely something that kind of puts them again, is this some sin? Is this because I did something wrong? And then that whole questioning actually begins at that point. And because appearance is something that you might see, face to face, and even older people for that matter, actually, we might think, their life's kind of done, they're kind of at the end of the road or whatever, but they seem to have a problem as well. Like they will think 100 times, and then they're saying, how will I go and meet the people in my club, or how will I go for my morning walk, or any of those things. So I guess as much as we're saying age, every age brings with it its own associations, especially psychological issues when it comes to disfigurement and or change in functionality. So I guess it's literally about coping, and what is the information they have, and what is it that they're really holding on to a great extent. So,
correct. And it's not just appearance, right? They sometimes have issues of drooling and so on as well. So and I think, Urvi, you've talked about how they are uncomfortable as to how they'll interact with their grandchildren and so on as well. So if you can highlight that a little bit.
Yeah, so I've seen the patients whose children are at certain age, like below 10, or grandchildren with that age. That time they feel that they like the grandparent or the parent's face is like adorable initial pre-cancer time, and post that they would look kind of scary. That is what they feel. So again, there comes a like how they look at themselves and how they think people would look at them. These are two different things. So they generally feel that now I won't get that same love from the children. And we have seen that children, when they visit the hospital, they stand slightly far off. That may be because of those tubes and pipes and those equipments all around the father or grandfather, whatever. But yes, it does affect them. Again, when they don't like to get plagued when they go out. In the restaurants, I've seen people ordering just the liquid food which they can consume through a straw. They don't want to show it to And again, I would like to highlight one more point, that not every time, it's not like that it is very visible, the disfigurement. But it doesn't depend on that too. Like I've seen patients who's got a very small scar or something, but they are very, very conscious about that. And we have seen patients who's got a huge amount of work done on their face, and they are like, they can cope very fast. Like both the things are okay, and it's okay to be not okay too. But yeah, so it depends on various factors. I've clubbed too many things together, I guess.
Dr. Aditya, post-op, are there specific care needs that are there specifically linked to the surgery itself?
So yes, so what, first of all, we tell the patients, all the patients, that they need to anticipate certain things. That is one, first and foremost, is the swelling. The bigger the reconstruction, the bigger the swelling is going to be. And the second thing is the scars. So they need to look out for the scars. Sometimes there are circumstances where we can sit and discuss with the patient regarding the scar. In some patients, we may have options to whether to give a scar here or to the side of the face, and some patients do have certain this thing about, I need a scar here rather than here, something like that. And also with the advance of science and everything, we have robotic neck dissections now. That is one part, that the swelling, when we do certain reconstruction, we give additional volume because sometimes after radiation, that tissue tends to shrink. If we give an exact match at the point of surgery, later on it becomes even smaller, and the radiation will cause it to shrink even further. And they will have again asymmetry. So they will have asymmetry to begin with, but we have to keep counseling the patient that the symmetry will go away. The patient will have to take care of his scar with scar massages. We tell the patients to do scar massages. We explain to them where and how much pressure to give, and how to make the scars more mobile, the texture to improve. We tell the patients to keep doing exercises for the neck, for the shoulder, because a lot of head and neck cancers lead to stiffness of the neck joint and the shoulder joint. So the joints need to be mobilized constantly. And also the part of the tissue from where it was taken. For example, if it was taken from the leg, they also have to take care of that leg also. They'll have to come for dressings and those sort of things. So yes, there is certain post-op care that the patient needs to take depending on the amount of reconstruction.
Right. Sheetal, are you going next?
So, and I'm sure there's a lot of physiotherapy, speech therapy, and swallow therapy that happens as well, right, Dr. Aditya? That I'm guessing standard protocol for most.
Yes, so we do have, at our HCG center here, we do have a dedicated speech and swallow therapy team also, who assesses the patient pre-operatively also and after surgery also. And we keep on monitoring the patient for his tongue mobility and for the healing of the stitches inside the mouth and those sort of things. And as and when the patient is fit to swallow and start with fluids, we start fluids, and then we start training him to use his new tissue inside the mouth. Then we train him to use that tissue to speak. And so yeah, speech and swallow is a very major kind of rehabilitation in these patients, apart from, of course, the physical rehabilitation and the psychological rehabilitation.
So there is a lot of factors that come into play, I think, for a head and neck patient, besides the psychological issues, yes. The functional issues, for sure. How do you think a lot of coping is required? How do you go about preparing families and the patient as well, either before or after the surgery, to deal with these issues?
Right. So typically what we do is when we're looking at a family as a unit, there are three things that we look at least. And that is specific to cancer. I mean, when a family has cancer or somebody is undergoing cancer. So one is about their functionality. So are they well functioning? Are they dysfunctional? Or are they in between? It's called intermediate functioning, where it is all based on how they communicate, how they feel that they are one, and how they resolute or move into conflict resolution. Okay, so if you look at it, based on these three things, at least that's what I've usually seen to have worked very well with the patients. Understanding their dynamics becomes very important, because there might be a whole lot of people involved in the care of this person, or who are obviously blood relatives to start with. It might be just the spouse or the children, or either the other way around. But understanding how they individually view it becomes important to see about, are they going to function well now when this person moves into something much more critical, and which is going to affect their quality of life in effect. To understanding or seeing who can we kind of use as a cheerleader in this. Is it going to be the spouse? Do we anchor? Is it the children who are going to be there, or is it the grandchildren? Like, who is going to be the primary caregiver, if I were to use that word, who's going to be part of this? And then slowly work with them to understand, what are their needs at that point, understanding what their distress is, in terms of this entire thing, and to say, how prepared are you, and what kind of support do you need? Because most of the time they feel like all their options are exhausted or limited. And I think with every additional person coming into the team, the finance or the costs obviously become a concern. So many a times people will say, oh, we don't need a psychologist, like the nurse will talk to me, the doctor will counsel me well enough. So I guess that is fine. Like, I would say that it is fine. But what happens is that if you don't kind of understand this for what it is, so we understand that families move into something kind of like a grief stage. And I think that was put forward by Kubler-Ross, where to reach acceptance, you have to go through denial, you have to go through anger, you have to go through bargaining, depression, and then you reach acceptance. So I guess as a family and as a patient per se, if they aren't going through those stages and reaching acceptance, they might be at different levels of acceptance. So what happens is, we think that acceptance happens maybe, or it should happen ideally in the beginning, like when some time to understand things. But most of the time, post-op is when reality really hits. And at that point in time, you are stuck to kind of just accepting or saying, I don't have a choice. I just need to accept it. But have you really accepted? Is the question I usually put forward to them when we have these talks about exploring, what they're really going through. So I would say that, yes, it is kind of like you need to bring in both people together to kind of get a holistic well-being, if that's what you want, once they are back home and need to function, because it is so interdependent of a sort. And unless they are interdependent at that point of time, independence for the patient or for them to kind of start doing things on their own might not happen. So the dependency tends to get worse. And I guess that is the biggest challenge that we have with majority patients who feel like they are a burden, or they are dependent on their close, family members, and it makes them very, very distressed. So I guess the whole idea, I think even the doctors, that is the whole thing. They want them to become independent. So the speech swallowing specialist and, the physiotherapist and everybody on board is trying to kind of get them to do that. So preparation would mean essentially kind of allowing them to get back into independence per se.
I just,
some of these things.
Go ahead.
Sorry.
Go ahead.
No, some of these things need to be done right away, or can they happen later on? For instance, the speech, the swallow, or seeing, a psychologist.
Right. So in the ideal situation, it's always before. But practically, it is very, very difficult. I mean, I would agree to it as well. I would sometimes it's been mentioned about the whole move to look at cure, look at, how fast you can get this resected or get the tumor out in time is something, that is of most importance at that point. But then you tend to forget that there is a mind and a body. So A lot kind of tends to get worse, like I said, post-op. So I would definitely say pre-op, at least somebody, like I said, right, anybody in the treating team can act as that facilitator to kind of just bounce these questions off. It could be a nurse who's probably trained. And I guess in the West, that's what happens, that patients are seen mostly by their nurse practitioners because they are trained in doing a whole lot of things and not just, what they probably do in an Indian setup. So empowering, I guess, somebody in the team goes a long way, to be honest.
Right. And does it get more complicated because of the fact that a lot of these cancers are directly correlated with tobacco usage? So, does the issue about blame and guilt in the family dynamics kind of make it more complicated?
Yes, I would say yes, because it might not be said and spoken at times, because it's like you're in the fire right now and you can't be saying these things out loud, but it's there, it's boiling within. And most of the time what happens post-op is there are these, fits of anger, fits of, I won't do this, I won't, go walking when the physio tells me, I won't do dressing, I won't come back to hospital. So you're going to be faced with a lot of, I won't do this and that. And then families get really frustrated and irritated, and definitely everything gets attributed then to saying that if I told you not to use it, how many years I spend doing that. But I have a lot of other patients who find meaningful conversations, saying that the patients themselves come back and say, I'm really sorry. I know you've told me all my life, to quit, but I didn't. And I guess it gives an opportunity sometimes for relationships to actually improve, because I mean, now that this has happened, it's kind of a way to bring people together as well. And there is forgiveness, there is some amount of catharsis, or saying that, this is like the worst thing that I could have done to you. So whatever it is, I mean, I guess there is some reconciliation, that there is a chance for it to happen as well. So yeah, so tobacco, yes.
Right. Urvi, do you have experiences that you'd like to share or to add something to that point?
Like we've seen that they deny the professional help initially, which is not good, I guess, because the general reason behind that is they feel that they've got a huge family support and they are very spiritual, and they don't need it. But actually, family is also facing this issue, how to accept the change in the appearance. So professional help is actually always very, very, very helpful and useful. This is one thing. Another thing is, like, we always try to, although it may sound very cliched, but we try to tell them that concentrate on the positive things you have, the things which you like in your body, and there are parts which you have to get used to. Like, you don't have to like it, but you have to get, cope with that emotion of not liking it or being okay with it. One more thing we tell them is, what is your worth? Like, your worth is more than the sum total of these imperfections in your body. So these are the things we tell them, and it works. Sometimes it doesn't work at times.
Right.
I have one point to add here.
Sure.
So when we're talking about the pre-operative, hello?
Yeah, go ahead.
Yeah, go ahead, Doctor.
Yeah. So this was already talked about by Michelle, but I just wanted to kind of address it separately, of having realistic expectations about coping and all these things. So this all should start with realistic expectations, because what do I mean by realistic expectations is that nowadays, not just nowadays, since a long time, media, the movies and television, they have falsely glorified and glamorized plastic surgery in such a very highly unrealistic and magical way, where they depict that an entire face can be changed with plastic surgery, before the back is put over the face and then the new face comes out. This has kind of altered the perception of plastic surgery in patients and in general population. Because this is not only absurd, but it's just basically scientifically impossible. So this needs to be understood by the patient as well as the family members, because the family members a lot of times come to me saying that we want the surgery and we have heard that plastic surgery leaves no scar. So please do it in that way. So I then again have to explain that every surgery will leave a scar. Maybe we can try to make it faint. Maybe we can try to hide it or camouflage it, or we can put it somewhere behind the ear so we can't see it. But yeah, so these kind of things also need to be addressed, and patients need to have a more realistic expectation for them to cope in the post-operative period.
Yeah, no, I think that's a very important point. I think the perception of plastic surgery is that it is, first of all, that it's cosmetic, and the fact that, you know, you get these perfect looking faces at the end of it.
Yes.
Yeah.
So, Dr. Aditya, if they don't opt for reconstructive surgery earlier on, and if they want to do it at a later stage, you know, post-treatment or a few years down the line, is that possible?
Definitely possible. Not in all the cases. So like I said, if there are highly advanced cases and a lot of tissue has been removed, it has to mandatorily be reconstructed at that point of time. But then there are a few cases where we go in for a simpler reconstruction to begin with, and we ensure that the patient finishes his radiotherapy, his chemotherapy, and all his other adjuvant treatment. He becomes disease-free for a certain time, and then we can come back and address his cosmetic concerns, his symmetry, and his other functional concerns a bit later on also. Yes, we can definitely come back and do those reconstructions later. And not just reconstructions, we can also address the patient's cosmetic concerns. If he has certain hollowness of the cheek, we can just put some volume into his cheek to, you know, match the other side. So yes, this is an ongoing process, and this keeps on continuing for quite a bit of time after the primary surgery also.
A couple of questions.
Like one of the things.
Sorry, go ahead.
Younger people, right?
Sorry.
Right, Aparna. I mean, for younger people who go back to work and things like that, they may want to explore these options as well.
Yes.
Right. No, I was also asking specifically around voice. You know, do you have, like, we've typically talked about the visible facial impact, but how does it impact when people lose their voice or their voice changes? Again, do you see, Michelle, any differences in you know, the emotions? Do I need to repeat?
Aparna, we didn't hear you.
Yeah.
Yes.
So are the emotions related to the change or loss of voice different?
So ideally, it depends on, I guess, what is anticipated or what the reality is. Okay. And I mean, in my past experience, we've had patients who are going to have like a total laryngectomy where they've been singers or they've used their voice in so many ways, like they've probably done storytelling or drama or anything. We've had patients who've recorded, you know, songs or things that they wanted to do before, to kind of just keep it like, you know, something that they will think back and relate to. But I guess speech therapy post laryngectomy is something that, depending on, you know, how the surgery goes, is something that patients can be given options to, depending on what the doctors say. And I guess it's kind of like an electronic voice, but then they tend to kind of use their esophageal speech at times as well to kind of bring that back out. So I guess there's not enough information out there in the open about options, but to be honest, in the West, there are these huge laryngectomy support groups. And I know even in the East, like in Asian countries, they have groups, and I've been lucky to have been part of some of these esophageal, you know, speech therapy workshops where we've had people who've been, some of them have been doctors who've had, you know, laryngectomy, who've come and kind of trained others in esophageal speech. And I know in Chennai, there are a couple of people who I'm personally connected with who do this on a routine basis to kind of empower people. And we realized that the effects that it can have, to have some light at the end of the tunnel, really goes a long way. I think even temporary kind of, you know, speech loss, for that matter, you know, for a little while is very, very distressing for a lot of people. And I keep thinking to myself, even at times, that what if it did happen to me? You know, we're all kind of going to kind of have thoughts that, one day if somebody says just pleasant thought, and I guess even for families, they recollect or they narrate experiences or talk about how this person used to command using their voice, or how they used to talk so loudly, or everybody could hear and everybody would know it with clarity, and this person kind of goes into not having speech. So definitely, I mean, it's literally our bread and butter in terms of communication, but then of course there is rehabilitation which can help you get back maybe, or restore some amount of the identity that we associate with it.
Yeah, so I think just on that, I'd like to just call out, because there's so few movies on this. There's one Bengali film called Kontho, which is based on a person who, lost his voice and uses esophageal speech. So because they're so rare, kind of films that talk about cancer in a positive way, we've kind of tracked some of this. So, yeah. Just one more question that has come in. Somebody's asking that my husband changed a lot after his cancer. He became irritable. He became very angry. How can I deal with that?
Urvi, I think you should take it. Like I've been talking a lot.
And I think both of you can answer it.
So firstly, you need to talk to the patient himself. And as I said, you need to reassure him or her, the husband, so him, about his worth and all, and how the family loves him as a person and don't love his personality. That is a thing, I guess, that will help. And we wouldn't know how which type of communication is going on between them. So we need to talk to them separately and then make them sit together and talk to them. And taking a professional help will definitely be a thing.
Right.
From my end, I think I would do some assessment, to be honest. When somebody says somebody has changed, there needs to be a pre and a post kind of understanding. So if this is something physical related, if it is something social related, then I think what we usually do is to put everybody through standard screening, distress screening, and we do the patient health questionnaire for depression and the generalized anxiety disorder questionnaire for understanding anxiety. Now, ideally, because we know that depression is very, very high, almost 50% of patients report depression, we need to have some kind of assessment objectively to understand, what they're actually going through. So I would do those things and then probably try and explore one as a patient separately, like Urvi was mentioning, and also as together as a family and together maybe as a couple as well. And if there are pre-existing issues in the marriage, or that, I mean, this could be a reason why it has flared up as well. It can also be, like I said, withdrawing, which is a very, very known thing that people do, because they do associate it to being, you feel like you're stigmatized, or that it's better you isolate, or that there's too much dependency. So, why should I, kind of make it harder on them? So it is so multifactorial, to be honest. And so there are many things I would say definitely to get them to meet somebody, either a psycho-oncologist or a psychologist, about what they are going through.
Or a support group may also help.
Sure.
Yeah. Anything else? Urvi, you have any questions or any comments?
Yeah, I wanted to ask Dr. Aditya that at pre-operative stage, can we show the patient some image where, how he or she would look like after the surgery? Because I've seen that it always hits very hard and they feel that they didn't expect this. So what to expect post the surgery?
Yeah, so there are two phases to this. One is there are techniques, there are models in which we can Photoshop the images and then show, but of course that is not recommended. I can rather, we can show pictures of patients of the same kind of surgery who have undergone before and after, and what they can expect realistically after the surgery. And I do show to a lot of patients who are quite inconvinced, or they're not convinced, and they're not kind of they want to know exactly how am I going to look, and you let me know how, and other things. But this is kind of a double-edged sword, because then when you show a certain picture, then that sits in their mind that this is how I'm going to look in the post-operative period, and out, or it is somewhere a little less or a little more than that, they sometimes get a little more agitated, and they say that you had shown me that picture, and I'm not looking like that. So it's kind of a double-edged sword, and if the patient is really understanding, these can be used as a very powerful tool to make the patient more educated and well informed about how he may appear in the post surgery. So yeah, with a pinch of salt, but yes, this can be done in a few patients, selected patients.
There's probably a role for technology to take that person's face and kind of do some virtual and AI.
Yes, there are already softwares that do that. But again, they give unrealistic expectations. They further fuel the unrealistic expectations of patients. So again, like, it's a double-edged sword. You may be able to show the patient something, but then if you don't achieve the exact result post-operatively, then the patient may get even more distressed. So
right.
Yeah, it has to be slightly with caution.
Right.
I think, sorry, just to add, I think always having a database of patients or family members, even for that matter, who are coping quite well, and bringing them back, I think, sometimes to kind of talk to other patients who might be going through similar things, but in a very, I think, a very filtered in, I think the doctor or whoever is recommending it needs to kind of have like a pre-existing understanding of what needs to be said.
Yes.
I think that really also helps, because I think in breast cancer, that's something that really boosts morale many times. So patient navigators definitely have a huge role to play. And I think in head and neck cancers, it often doesn't happen because, those who are doing well are not to be seen anywhere, to be honest. And we also, would love for them to come back and kind of share and give inspiration to other people, and seeing them functionality and all of that, I think, makes a bigger difference as against maybe just appearance, which is probably something that they're kind of grappling with. So.
Correct. Yeah. No, I think you make a good point that we do need more survivors to come forth and share their experiences and come and be patient support advocates. There's a question that's come in, which I don't know, Dr. Aditya, how easy it is to answer, but how long does it take to, or I don't know for whom it's Dr. Aditya or Michelle, both, how long does it take to cope with the change that occurs due to plastic surgery, depending on the mental status of the person?
I think Michelle would be
So I think it all depends on the individual, to be honest. We usually say, it takes at least about 3 to 6 months for you to actually do that, because that's how long you might take to kind of finish your post-op rehabilitation and kind of get back into normal functioning. But it can happen sooner, it can happen later. But like I said, it's not just one factor, and I don't think it's all physical. We were mentioning as well, that we might have had bigger surgeries and people are very, positive, and they're very, very, adapting very well, as against somebody who might just have a scar who is not able to cope. So it's a very individual kind of situation. And I would say that if somebody is grappling with it, again, come and talk to somebody who is probably going to be able to help them professionally.
Right. Okay. Any other questions anybody has? Any comments?
I want to say something.
Sure.
As a society, we need to learn things like the stairs and glares. Stairs and glares are a big challenge for such patients or anyone having body image issues. So that is a point I wanted to make.
Actually, you bring up a good point, Michelle. What is it one thing or three things that, okay, I think my connection is again unstable. What are the one thing or the three things that other people, not just the immediate family, but friends and colleagues can do to help the situation?
I think Urvi brought up the point. So
yeah,
I
know. So with both,
yeah.
I think.
I think stigma in itself, like if you look at just mental health, I mean, we are quite stigmatized working in the field. I guess people don't understand that there is a professional way of how you handle what somebody is dealing with emotionally. But I think there is not enough stories that good things can happen in cancer, to be honest. Especially with head and neck cancers, where tobacco becomes like the single most modifiable risk factor in head and neck cancers. I mean, there's a lot of lobbying about tobacco, but I think when it comes to understanding it for what it is and to kind of break the addiction or break that pattern, very few people seek help. And obviously, when they are met with something which is life limiting or life threatening for that matter, they are pushed very hard to kind of make these choices. And it's like, there's no other option to do it. But I think it's about creating awareness that there is life after cancer, because that is something that we don't really see. And I think empowering our own teams, I think, becomes a huge kind of effort that we need to put in. I think when there are so many other people like nurses and physiotherapists and so many other people who are involved in looking after the patient, I think empowering those teams to kind of be little bits of information to kind of make a larger picture. I think that is also very, very essential. So essentially moving from multidisciplinary to interdisciplinary, so you everybody interacts together to kind of find the best solutions for patients. So I think that's something that I think I would like to say really goes a long way. And I think in the West, that is something that everybody is exposed to, as against in India, where it's bits and pieces. And for the caseload or the number of patients, like even Dr. Aditya was saying, despite COVID, people still are coming into hospitals and worrying about, future. So the teams really need to be on board with that. So,
yeah. Urvi, did you want to add anything to that?
Totally agree with that. Yeah.
Yes, Shita.
No, I totally agree with what Michelle was saying, because we have a lot of patients who are scrambling for information, right? And
correct.
Like you said, it's in bits and pieces. So if it is an integrated care system, it makes it easier for everyone.
Correct. Now, Urvi, to the point about how the friends and work colleagues can help.
Yeah, so we all, as I said earlier, we all mean well, and when we say that you look good, but we should concentrate on other parts, like this shirt really suits you, this color suits you, or your hair look really good today. Why we need to say that you look good? So no, that gives some negative thing to the patient. So we, as a society, we need to learn how to deal with this. Why only cancer patients? Like maybe alopecia, or there are many other kind of illnesses, or where you have disfigurement or any body image issue. So we as a society need to learn that. That was the point I was making.
Yeah, no, I think it's a point well made. I think we've kind of crossed our time, so I will say thank you to our panelists, Dr. Aditya, Michelle, and Urvi. Thank you, Sheetal, for co-hosting, and thank you to our audience. I know it's difficult out there, so keep the faith and stay. I can't say stay positive. Keep your heads up, and hope you get through this. And I think the key takeaways really are that be open about your feelings. It's okay to ask for help. In fact, it's important if you seek professional help. Have realistic expectations while you discuss your reconstruction options as well. Keep your channels of communication open. And as a society, let us be more empathetic and be,
not come up with silly comments, and do the best we can to learn what the right comments and reactions should be. So thank you, everyone, once again.
Thank you.
Thank you for having me. Thank you.
Thank you so much, everyone.
Thank you for having
Thank you.
Bye-bye.